Good afternoon, everybody, and thank you for the kind invitation. I thought I had 20 minutes, but I see 15 over there, and my talk is a little long, but I'll try to finish it at the earliest. Oh, okay, fine. So let me not waste more time. I'll be discussing approach to and management of hyperthyroidism in children. So hyperthyroidism, as you know, is an excess production of thyroid hormones by the thyroid gland. Another term we commonly use is thyrotoxicosis, and this term is actually used for the clinical and the biochemical manifestations of hyperthyroidism. The incidence of hyperthyroidism in children and adolescents is 1 per 5,000. The most common cause is Graves' disease, and peak incidences during adolescence. It is more common in girls during adolescence, and the ratio of females to males is 5:1 at that time, and it's not so high at a younger age, which suggests that maybe estrogen has some role in the pathogenesis of this disease. Now coming to the causes. So we either have increased synthesis of the thyroid hormones. This can be seen due to increased TSH receptor activation, as we see in Graves' disease. It could be due to an activating TSH receptor mutation or in McCune-Albright syndrome. It could also lead to autonomous thyroid secretion, as we see in toxic adenoma and toxic multinodular goiter. The second cause is usually because of increased release of preformed thyroid hormones. The first one was increased synthesis. This is increased release of preformed thyroid hormones, and hence this is transient and tends to settle down with time. And this can be seen in hashimotosis, which has already been discussed. This is the toxic phase of Hashimoto's disease, where because of the thyroiditis, there is a release of high quantities of thyroid hormone. It's also seen in subacute autoimmune thyroiditis, bacterial thyroiditis, and radiation-induced thyroiditis. Increased TSH secretion can also cause hyperthyroidism, and this can be seen in TSH-secreting pituitary adenomas and in pituitary thyroid hormone resistance. And then it could be drug-induced because of amiodarone and contrast agents which contain iodine, or intake of thyroxine, which could be iatrogenic or factitious. So since the time is less, my main focus is going to be on Graves' disease today, because that is one of the commonest forms of hyperthyroidism that we see in childhood. And I'm going to focus more on the management. So the pathogenesis of Graves' disease, as you know, it's because of stimulating antibodies to the thyrotropin receptor, what we call as the TSH receptor antibodies. These are also known as the thyroid stimulating immunoglobulin, because these are the stimulating antibodies. There is a strong genetic predisposition in 80% with a positive family history, although environmental factors may contribute, and immune dysregulation because of stem cell transplants, etc., may also induce this condition. Now coming to Graves' ophthalmopathy. This is also a part of Graves' disease, and this antibodies are produced against a TSH receptor-like protein which is present in the retroorbital connective tissue. And Graves' ophthalmopathy is actually less common in children compared to adults. Then we have a triad which includes Graves' dermopathy. This is also because of antibodies against the TSH receptor in the dermal fibroblasts, but we usually don't see this commonly in children. Now the other associated conditions which may occur with Graves' disease are increased frequency of other autoimmune endocrine diseases like type 1 diabetes, adrenal insufficiency. They could be associated non-endocrine autoimmune disorders like celiac disease, vitiligo, SLE, etc. And as you just heard, Down and Turner syndrome cases are also at a higher risk of developing all autoimmune thyroid diseases. Clinical manifestations, you all know very well, these are because of the excess of thyroid hormones, because of the sympathetic activity. There is tachycardia, palpitation, weight loss, increased appetite, diarrhea, tremors could be present, and other neurological problems could be there. In children, one of the commonest ways of picking it up is a poor attention span, poor school performance, change in handwriting, or behavioral changes are the first symptoms sometimes. It affects the bone due to increased bone resorption, increased sweating, etc. may also be present. Coming to the eye symptoms, stare and lid lag are there. Graves ophthalmopathy includes proptosis, that is exophthalmos, impairment of eye muscle function, periorbital edema, and it can also affect growth and puberty. A goiter is usually present, mostly it's a large goiter which is smooth, fleshy. Nodules are usually not palpated. You may auscultate a bruit. Sometimes a large solitary nodule or multiple nodules may be present as in adenomas or multinodular goiter. Now coming to the diagnosis. We do a simple thyroid function test. Free T4 and T3 are elevated with a suppressed TSH. Now it is recommended that for monitoring in these children, we do a total T3 and not a free T3, because the total T3 is a more reliable assay in terms of managing the, modifying the doses of drugs. So try to stay with total T4 and T3, or at least T3 should be total and not free if possible. So normal if the FT4 is normal with a suppressed TSH, then we think of subclinical hyperthyroidism. If there is a predominant T3 elevation, this could be due to an autonomously functioning nodule or a toxic multinodular goiter. If the T4 concentration is proportionately more than the T3, then it is suggestive of destructive thyroiditis. If the TSH is increased or normal, then we think of a TSH secreting pituitary adenoma or pituitary thyroid hormone resistance. So these are the various forms of hyperthyroidism that we may diagnose on with a simple thyroid function. Now coming to the thyroid antibodies, we measure the TSH receptor antibodies to confirm the diagnosis, and these are positive in 94% cases, and this is a very simple test which is easily available now. I know at least Lal's lab is doing it all over India, and it's easier than doing scans. Now if this is positive, I think with the clinical picture the diagnosis is confirmed, but if these are negative, check for anti-thyroid peroxidase and thyroglobulin antibodies also to rule out hashimotoxicosis. These antibodies can also be present in Graves' disease, but the levels are usually much higher in Hashimoto's toxicosis compared to Graves' disease. Now coming to a radionucleotide scan, which used to be our first investigation earlier when we didn't have the antibodies, the receptor antibodies available. But now we usually do that if required, and if the TSH receptor antibody is negative, and the isotope iodine-123 is the radionuclide of choice. And usually a diffuse increased uptake is seen throughout the gland in Graves' hyperthyroidism. If there's an increased uptake in the location of a palpable nodule and the rest of the gland does not show an uptake, we think of a toxic adenoma. If it is a spotty uptake, then we think of a toxic multinodular goiter. And if the uptake on the scan is low, then we think of a destructive thyroiditis. So the uptake will be reduced in destructive thyroiditis because it is due to the preformed thyroid hormone. So the uptake is going to be low. So I've just summarized in the next two slides. If the radioactive iodine uptake is high due to increased synthesis of thyroid hormone, then I have summarized the conditions here along with the antibody profile. And if it is a low uptake due to increased release of preformed thyroid hormones, we think of a thyrotoxic phase of thyroiditis, and that is summarized in this slide. So this is a short case of a 15-year-old girl with progressive swelling of the neck for a few months, no pain, hoarseness, weight loss is there, palpitation, excessive sweating is there, school performance is normal, periods are normal, past history was normal, history of hypothyroidism is positive in the family. Her height, weight, you can see it's here, pulse is increased, BP is slightly high, no tremors, eyes are normal, the thyroid gland is enlarged, irregular surface, asymmetric, but no nodule was felt, no cervical lymphadenopathy, and systemic examination was normal. So this is a picture, and you can see that the goiter is asymmetric over here. So a CBC, ESR, LFT was done, thyroid functions. Do we have a pointer? Yeah, okay. Okay. So thyroid functions, you can see T3, T4 were high and TSH was suppressed. The TSH receptor antibody was high, it was 7. Scan was not done and ultrasound was done because the surface was irregular, but no nodule was seen on ultrasound. So this child was started on methimazole 15 milligram 12 hourly, and propranolol. And thyroid functions were done after 6 weeks and 3 months. These are after 6 weeks and these are after 3 months. The T3, T4 I have normalized and TSH is still low. So it may take time for the TSH to normalize. And we gave propranolol to cover up for the adrenergic symptoms because it will take time for the drug to act. It takes about 6 weeks for it to block the thyroid hormone synthesis. So to cover up for that period, we have to give beta blockers. So at this time, because T3, T4 were normal, pulse BP were okay, propranolol was stopped. But this child did not go into remission for the next 3 years. So what do we do? The parents are worried, they're hassled. How long will my child keep taking medicine? Is there anything else that I can do? So coming to the treatment now, what are our treatment options for Graves' disease? So first line of treatment usually in most cases, exceptions may be there and we'll discuss it, is anti-thyroid drugs. These are thionomides which block the synthesis of thyroid hormones, and there are 3 drugs which are available in the market: methimazole, carbimazole and propylthiouracil. The second option that we have is radioactive iodine ablation of the gland, and the third is surgery, thyroidectomy. So starting with the anti-thyroid drugs, this is the first line of therapy in most patients because there is a chance of permanent remission. There is no risk of permanent hypothyroidism and the cost is also low. Methimazole is the recommended drug of choice. Carbimazole can also be used, but PTU should not be used because cases of liver failure have been related due to PTU. So the Endocrine Society and American Thyroid Association suggest that we do not use it in children unless, once in a while, if we have no choice, then short-term use could be done. Amongst the beta blockers, we've already discussed for 6 to 8 weeks, propranolol can be used. It also inhibits the peripheral T4 to T3 conversion and a dose of 0.52 milligram per kg and 3 to 4 doses. Atenolol can also be used. This is cardioselective and it is a single dose. So if there are compliance issues, it may work better and the risk of bronchial asthma is lower with this too. Now, the initial dose of methimazole is 0.25 to 1 milligram per kg per day, which can be given if the dose is not high. You can give it as a single dose or in 2 divided doses, available as 5 to 10 milligram tablets. Starting dose will depend on the initial severity of the disease, the size of the goiter, and depends on the thyroid functions. Try not to use very high doses of methimazole, more than 30 milligram, or carbimazole, more than 40 milligram per day. Children less than 7 years of age may need higher doses, and avoid block and replace method. Now earlier this was a popular method where we would give anti-thyroid drugs, and when the child became euthyroid or hypothyroid, then thyroxine would be added, and they felt that was better, it would reduce the antibodies. But now the thought process has changed, and in this way we are continuing with high doses of anti-thyroid drugs for a long time, and we don't even come to know when remission has occurred. So it's not a popular method anymore. Before we start treatment, measure baseline WBC, LFT, and low counts and raised SGPT could be part of hyperthyroidism also. So it's just a baseline. Do the thyroid test every 4 to 6 weeks initially. Once the thyroid functions have normalized, we reduce the dose by 30 to 50% and monitor every 3 to 4 months. The TSH may remain suppressed for several months after the patient has become euthyroid also. Now, coming to the side effects of these drugs, minor are rash, arthralgias, etc. The major side effect is agranulocytosis, which is seen in 0.1 to 0.5% cases, and sometimes vasculitis-like symptoms, which are more common with PTU. Hepatitis is also mostly with PTU, and the highest risk of complications is in the first 3 months of therapy, and maximum up to 9. After that, very few people will get side effects. Also, there is a risk of birth defects in girls who plan on pregnancy if they're on any of these anti-thyroid drugs. Now, I won't go into details about agranulocytosis, there's not enough time, but if there's a mild lowering of the counts, stop the drug for a while. If they're normalized, restart. But if there is actual agranulocytosis with a count less than 500, then you have to stop the drug, and it's a contraindicated to use oral medication again. Now coming to stopping of therapy, we gradually reduce the dose. If the antibody titers are positive, we continue treatment. If they're negative, there is a good chance that the patient will enter into remission. If we make a decision to stop the drug, recheck the thyroid functions regularly, and you have to keep a watch on them for a lifetime. Remission is defined as being euthyroid for at least 1 year after cessation of therapy, and the rate of remission with antithyroid drugs varies from 15 to 30 to up to 40% in the first 2 years of life. And some studies suggest that if we give long-term treatment up to 2 years, the remission rates get much better. So low chance of remission is if the antibodies are high in younger patients, severe disease, large gland, low BMI and prepubertal status, and relapse rates vary from 3 to 47%, and most happen within a year, and treatment of relapse is the same. You have all the 3 options available again. Now coming to the other modalities of treatment, when do we use them? When there are major side effects with antithyroid drugs, failure of remission with prolonged treatment, relapse, adolescent girls who may want to plan pregnancy, leaving home for college, poor compliance, and a large gland. So coming to radioactive iodine, which was the second way of treating it, ablation of the gland with iodine 131, the radioactive form results in hypothyroidism and a lifetime of thyroxine. Do not aim for euthyroid state because low dose radiation to the remaining gland increases the risk of thyroid cancer. It's the second line of therapy in children more than 10 years, but it can be considered between 5 to 10 years if low doses of radiation are used. The dose is 200 to 300 microcurie per gram of thyroid tissue, and hypothyroidism will develop 2 to 3 months later. Ultrasound is used to measure the weight of the gland. 1 cc is equal to 1 gram, and antithyroid drugs are stopped a week before ablation. Contraindications are age less than 5 years, destructive thyroiditis. If there is severe hypothyroidism, let the thyroid functions normalize and a very large gland. And positives are convenient, less lab monitoring, doctor visits, no evidence that it will cause or worsen ophthalmopathy in children or adolescents, and there is no effect on babies born to mothers who were treated with this modality. Immediate problems are local pain, risk of thyroid storm, doesn't affect the size of the gland. So if you have a huge gland, it still may look cosmetically bad, and long-term risk of cancer is controversial. And these are some of the studies which show that after 36 years, none of the patients develop thyroid cancer or leukemia. In 18,000 patients, they found an increased risk of death from solid cancers, including breast cancer. Another study where they found increase in the respiratory and gastric cancers, but this was related more to the hyperthyroidism. So the jury is still out there trying to decide which is better, radioactive iodine or surgery. I'll go quickly through surgery. I think you're all familiar. Second line of therapy in children less than 5 years can be considered between 5 to 10 years if there's a large goiter, and it is the third line for those who fail radioactive iodine therapy. Near total thyroidectomy is done, and it results in permanent hypothyroidism, the risk of transient hypocalcemia, permanent hypoparathyroidism, and injury to the recurrent laryngeal nerve is possible. And I'm going to skip neonatal Graves' disease, and I would like to summarize that basically we have to, even now, the first line of choice is antithyroid drugs, and in Europe, etc., I think it seems to be the more popular way of treating. Treatment has to be individualized. If the patient is on low doses of antithyroid drugs and is okay taking it, has no side effects, compliance is not an issue, it is okay to continue with it. If we have children who cannot handle it, there's a compliance issue, have developed problems, or they just don't want to go on with medicines and lab tests, etc. As I mentioned, one could give them the option of ablation or surgery, but surgery should be done by a very experienced thyroid surgeon who's doing a high volume of surgeries. And I think I'm going to skip neonatal. Thank you so much.